I call to order. Good morning. I call this hearing to order. A quorum is present. Without objection, the chair is authorized to declare a recess at any time. Before we proceed, I would like to go over a few housekeeping items for our remote hearing. First, if you are experiencing connectivity issues, please make sure you or your staff contact our designated technical support so these issues can be resolved immediately. Members participating remotely must continue to use the video function for the duration of their participation in the hearing unless they experience connectivity issues or other technical problems that render the member unable to fully participate on camera. It is committee and subcommittee policy that members will remain muted when not recognized. Just like turning your microphone on and off during an in-person hearing, this is out of courtesy to all members on the committee, and so that background noise does not interfere with another member who is recognized to speak. When you are recognized, you will need to unmute your microphone and pause for a couple of seconds before speaking so that we will be able to hear everything you say. In order to ensure everything members say is captured on the live stream of this hearing, I ask that members pause for 2 to 3 seconds before beginning to speak. If you wish to have a document inserted into the record, please ask for unanimous consent and have your staff email the documents to veteranaffairs.hearings@mail.house.gov. It will be uploaded to the committee document repository. Without objection, members will be recognized in order of the subcommittee seniority for questioning witnesses today. This will make it easier for me to ensure all members participating have an opportunity to be recognized. I ask unanimous consent that Representatives Sharir and McMorris Rogers from the Washington delegation be permitted to join today's hearing to speak to their concerns about the program should they be available. Without objection, so ordered. Does any member have a question about the procedures for this hearing? Hearing none, we shall proceed. I now recognize myself for opening statement. Good morning, and thank you for joining us as we continue the subcommittee's oversight of the Electronic Health Record Modernization Program. This marks the first time that we have Deputy Secretary Donald Remy, who serves as the accountable official for the program before our subcommittee. First, I would like to welcome you, Secretary Remy, and say that I look forward to working with you to ensure that this program improves the lives and healthcare of our veterans. It has now been over a year since Cerner went live in Spokane, and the project has been so riddled with issues that Secretary McDonough announced a strategic review, and there has not been another go live anywhere else as a result. Whether these issues are with Cerner or due to VA's mismanagement of the project, it needs your leadership to get back on track. 3 weeks ago, I met with the leaders and staff at the medical center in Spokane. What I heard loud and clear is that the frontline staff doesn't feel heard, and they continue to experience numerous issues with the system that make their lives more difficult. I heard things like, we are emotionally, physically, and mentally exhausted. We don't get the feeling that these things will improve, and quote, staff would like to care for patients using a record they can trust. We are beating our heads against the wall to make Cerner function, and it is an aggregation of inefficiencies. They told me they have had to hire staff to manage the manual workarounds that have been created to ensure veteran safety in this system. This tells me that the system is not creating the efficiencies we were promised. We've also heard that VA's National Center for Organizational Development has released the results from a survey that was conducted of manned grant staff personnel. The results of this report are extremely concerning. They show that people at Spokane VA and its associated clinics are demoralized and unhappy. The vast majority of respondents express that their morale and job satisfaction have worsened because of the Cerner implementation. I want the folks in Spokane to know that I hear you, and I'm committed to making sure that your voices are heard. I also want to thank you the frontline staff in Spokane for bravely undertaking this major EHR modernization effort during a global pandemic. I know it was not easy on you. I want to get to your testimony and questions, but by the end of this hearing, I need to hear answers to the following questions. At what point is VA going to fix these issues? Is VA going to fix these issues before moving on to another facility? What is VA doing right now to improve working conditions for staff having to utilize the Cerner system? I am open to working with VA on finding a solution to these issues, including an independent evaluation of the EHRM program. I worry that the GAO and the OIG don't have the bandwidth to conduct a full top to bottom evaluation of both Cerner and the deployment program. Our subcommittee needs as much information as possible to continue to provide oversight to this program. And I want to make sure we are all open to all available options to get things right. We have a lot to discuss today, and I hope to gain a solid understanding of VA's plan for moving forward with this program. Deputy Secretary Remy, I look forward to your testimony and getting an update on your plans. With that, I would like to recognize my colleague, Ranking Member Rosendale, to deliver any opening remarks he may have. Mr. Rosendale.
Thank you, Mr. Chair. Appreciate you offering over to me today. I appreciate Deputy Secretary Remy and all of our witnesses for joining us today. Besides the leaves turning different colors right now, the situation appears to be much the same as it was during our previous hearing in July. Unfortunately, the strategic review has been a disappointment, and conveniently, its report was not shared with us until after additional funding was already allocated for the EHRM program. The strategic review made sound recommendations for some of the key problems with the EHR, ignored several others, and so far has implemented virtually nothing. Sugarcoating the situation does not help anyone. Veterans expect us to get the truth and put forward solutions. VA has decided to restart the clock and move ahead with the system in Columbus, Ohio, even though Secretary McDonough assured us the system would not be expanded nor continually funded until the Spokane facility was, quote, fully functional. We had these discussions and he gave us those assurances. Upon learning this, my colleagues and I sent Deputy Secretary Remy a letter expressing our concerns. It seems this decision has been made without demonstrating tangible improvements in Spokane, without putting forward quality metrics, and seemingly without the VA meeting its own criteria to move forward. We are left to collect our own information. It appears that 1 year after the system went live in Spokane, productivity is recovering painfully slow and morale is not improving at all. All the while, the VA continues to shovel money at this problem, achieving nothing more than the enrichment of Cerner and a small group of contractors. I believe three things need to happen right now in order to salvage this program. First, the VA officials have to agree on quality, performance, and safety metrics and make them public along with the supporting data. In other words, a yardstick to measure the EHR's performance that everyone can see. The program should only move on to other facilities if these indicators are pointing in the right direction. If that does not happen very soon, it is our responsibility to legislate it to make sure it does happen. Second, VA must implement all the strategic review recommendations, starting with the reorganization. Reshuffling offices will not solve all of the root causes of the problems that we are experiencing, but there is absolutely nothing to be gained by dragging this process out. Third, I believe that the scope of the Cerner contract should be corrected. Ever since the program began, VA has been expanding the scope of the contract, some of it only loosely related to the EHR. This pattern raises additional arguments against the sole source contract process. This may have been well-intentioned, but has strained resources and obligated Cerner to fix other VA systems that it has no control over. The VA should manage this ancillary work, and Cerner should concentrate on the core EHR. On top of that, the contract must be reined in because the program is heading for a huge budget overrun that can no longer be denied. The Inspector General found as much as $5.1 billion of infrastructure costs that were excluded from the cost estimate. Until the VA puts forward a complete life cycle cost estimate, which we are told is a year away, no one will know actually what the true cost of this program is. The only hope to get the cost under control is to reduce the spending now. We have repeatedly called for this, and VA's determination to ignore it flies in the face of common sense. My expectations for the EHR will never change. They will be the same in this hearing as they have been in all others. The system has to improve veterans' health care, not complicate it. It should make hospital operations more efficient, not grind them to a halt. It has to make it easier for veterans to communicate with their doctors, not confuse and frustrate them. Through all the jargon and bureaucracy, we can never lose sight of those simple principles. Mr. Chair, I yield back. Thank you.
Thank you, Mr. Rosendale. I would now like to recognize my colleague, Mr. Takano, Chairman of the Veteran Affairs Committee, to deliver opening remarks that you may have. Chairman Takano.
Well, thank you, Chairman Ravan, and thank you and the ranking member for holding this very important hearing. I'll keep my remarks short. We have a lot of ground to cover, and I really want to get to the questions. For context, Mr. Remy, in 2018, when VA made the decision to sign a sole source contract with Cerner in hopes of creating a single record, I had misgivings. Then Chairman Dr. Rowe and I both felt strongly that VA had no choice but to purchase a 21st century EHR because Vista was struggling to keep up with modern technology. However, the sole source nature of the contract, the influence on the process by outsiders, and actions of the previous administration, as well as the sheer cost, required that Congress conduct thorough oversight. This is why the committee stood up the Technology Modernization Subcommittee and why the continued oversight of the EHRM program remains critical to its work. Now, I look forward to working together and making this important program work for our veterans. Now, given VA's past challenges with modernization programs, it is critical that we work together to review and possibly revise the management structure surrounding IT acquisitions in general and the EHRM program specifically. Now, the EHRM program is vital to improving the transition of care for service members as they move from active service to veteran status. It is also a prime opportunity to improve what is already world-class patient care at VA. Our veterans expect and deserve nothing less. So it is incumbent upon us to ensure that this program is successful. We are hearing from staff in Spokane and beyond that the system is not meeting their needs, that it is actually making their jobs harder, and that there are very real concerns about patient safety. This is not acceptable, and I hope that VA can turn this around. Secretary Remy, I thank you for being here today, and I look forward to our conversation. Mr. Chairman, I yield back.
Thank you, Chairman Takano. I will now recognize my colleague, Mr. Bost, Ranking Member of the Veterans Affairs Committee, to deliver any opening remarks you may have. Mr. Bost.
Thank you, Mr. Chairman, and Deputy Secretary, thank you for being here today. You know, the Spokane Medical Center went live with Cerner's EHR 1 year ago today, or 1 year ago. We actually had already talked about that today. You know, initial reports looked okay, but as time went on, things got worse. Appointments took twice as long. Orders and notes in the medical records were lost. Veterans struggling to refill their prescription. Employees were confused, then frustrated, then burnt out. These issues and others were not unexpected. This committee raised these concerns multiple times before and after going live. But VA underestimated how serious the problems were or denied them altogether. You know, what worries me is that these problems keep happening. Some VA leaders still believe that it is all because employees are resistant to change. In other words, they blame the staff. This is inaccurate and unfair. It is also no way to manage an organization. It is painfully clear that Spokane is a mess because the EHR and how VA and Cerner implemented it. In July, I said the strategic review was the last and best opportunity to make meaningful changes and get the EHRM on the right track. You know, I'm disappointed that none of the strategic review's recommendations have been fully implemented. I'm also disappointed that according to the employees in Spokane, the EHR has not meaningfully improved. And despite all of the VA is proceeding, but despite that, all VA is proceeding with Columbus, Ohio. Let me be clear. The problem in Spokane will become problems in Columbus and every other facility. This will not change until we address the fundamental issues in the system. You know, I'm not in support of going live until the VA and Cerner can show us improved quality metrics and the data to back it up. Over the past year, all we have seen is a few cherry-picked superficial metrics with no supporting data. Some people may hope that the committee will simply look the other way and tolerate poor performance. Well, I can tell you that, and can guarantee that that will never happen. And if you listen to each one of us giving our open statements, I'm pretty sure you understand how disappointed we are. And this is a truly bipartisan effort to try to get you straightened out. We owe it to the veterans. We owe it to the employees to maintain high expectations. Deputy Secretary Remy, you were not in charge when some of these decisions were made. We do not hold you responsible for past failures, but you are in charge now. We hold you responsible for changing the way the program is managed, not just putting new labels on the same old offices. We hold you responsible for aligning the budget and with what it actually is happening on the ground. We hold you responsible for proceeding to Columbus only when the system is safe and fully functional. From our conversations, I know you appreciate the gravity of this responsibility. I know you understand the impact this project has on the healthcare of 7 million veterans. And I am here in your corner to help and to make sure this will succeed. I look forward to today's hearing. And with that, Mr. Chairman, I yield back.
Thank you, Mr. Bost. I will now introduce our witness for today. The Honorable Donald M. Remy was nominated by President Biden to serve as the Deputy Secretary of the Department of Veteran Affairs. Mr. Remy's nomination was confirmed by the Senate on July 15th, 2021, and he was sworn in by Secretary Dennis McDonough on July 19th, 2021, as the 9th Deputy Secretary of Veterans Affairs. We will now hear a prepared statement from Secretary Remy. I will remind you to please pause for 2 to 3 seconds before speaking so that the recording will capture all of your words. And please remember to do so when answering members' questions. Thank you. Your written statements in full will be included in the hearing of the record without objection. Secretary Remy, you are now recognized for 5 minutes.
Chairman Mervan and Ranking Member Rosendale and distinguished members of the subcommittee and invited members of Congress to this hearing. As was mentioned before, this is my first appearance before the subcommittee, and I want to thank you all for your steadfast support of our veterans, of their families, their caregivers, and survivors. And as importantly, I want to thank you for the opportunity to testify today on VA's electronic health record modernization program. And before we get to today's topic, I want to update you quickly on concerns that many have expressed related to supply chain. As we know, the pandemic exposed global and U.S. supply chain weaknesses, and we expect the manufacturing and distribution disruptions to continue for some time. And as the virus spread, overall consumer demand decreased and industrial activity in turn decreased. Yet with the increasing level of vaccinations globally and the end of lockdowns in many nations, consumer demand increased dramatically while supply chains continue to face big challenges, including worker shortages and limitations in access to raw materials and key components. I want you to know that VA is actively addressing these challenges, implementing near-term methods to ensure internal VA supply chain resiliency, including monitoring the ability of our suppliers to fill our orders completely and timely, identifying alternatives for preferred products, and treating medical products as enterprise assets. We know that effective national response requires resilient public health supply chain anchored in domestic manufacturing capabilities so that care and preventive measures can reach our veterans. Sustaining the resilience of the supply chain is critical for ensuring the health and wellness of the nation as well as for national security. And VA is working closely with the White House and executive branch agencies to develop and implement the actions identified in the National Strategy for a Resilient Public Health Supply Chain. Bottom line here, these challenges are very real, but we're mobilizing to address them. Now back to today's very, very important topic. As you know, I'm a new member of this amazing team at VA, 3.5 months on the job. My journey to this role includes serving as an Army officer, as a political appointee, working in the C-suite of major enterprises, and as a partner in global law firms. And throughout these experiences, I've learned that success of a program is not the sole responsibility of one leader, one facility, or one vendor. Instead, the success or failure of any program boils down to a partnership between everyone involved, a partnership where responsibilities are shared and accountability is assigned and owned. Secretary McDonough has tasked me with building that type of partnership on EHR implementation to create a platform that seamlessly delivers the best access and outcomes for our vets and the best experience for our clinicians and our providers. And that's exactly what I'm going to do. As was said before, regardless of what's happened before, and regardless of how long I've been in this job, I am here now. And that means I own it. I recognize that. And I plan to lead this unified enterprise-wide governance effort and make the best use of our resources as we implement this system across the enterprise. And I promise to be accountable to you and collaborate with you as we move forward. As members of this subcommittee are aware, as I've heard in your opening comments, our handling of EHR to date has failed to live up to this program's promise, both for our veterans and our providers. And the findings of the strategic review, well, they're reflected in my written statement, and I'm not going to provide details, but happy to answer questions. I want to convey 3 points on what we're doing to move forward right now. First, that we're learning from the implementation mistakes of the past. Second, that the Cerner system works, and I believe we've properly positioned it for success. And third, that we're bringing together all relevant stakeholders to ensure an effective EHRM deployment. Now, on the first point, I appreciate our employees on the ground at Man Grandstaff. I take their concerns very seriously. I've spoken with them just as you are, speaking with them regularly, and we've taken steps to work with them to address the concerns that they're articulating. And I know we'll talk a little bit about that today. We're solidifying our processes and we're improving with lessons learned. Those lessons learned will allow us to take a closer look at patient safety, data management, access to care, productivity implications, and human capital requirements. On the patient safety issue in particular, I need to be crystal clear. We take seriously every possible or potential safety concern using a detailed process that involves mitigation and, most importantly, prevention of future occurrences. There is nothing more important to VA employees or to me than patient safety. The second point is that the Cerner EHR system works. It's been deployed in over 35 countries. It's been used in more than 27,000 private provider facilities and 5,900 hospitals, and it's currently being implemented at DoD sites all across the nation. So the natural question is, if it's working so well in other healthcare systems, why won't it work at VA? Well, I think it will work at VA. But I gotta say, we're making a big change from a system that allows for site-by-site differences in how staff do their jobs to one that will provide standardized workflows across the enterprise. This change, I believe, will benefit veterans and providers over the long run. But it is a difficult transition, one that goes beyond just the technology of the system itself. And that brings me to my third and final point, breaking down barriers to get the job done. Throughout the history of this project, silos have been unintentionally created within VA. I've seen some of these barriers myself, but now I recognize it's my job to make sure every key stakeholder has a voice in EHRM, not only in building the system, but in testing the system and training on the system to assure accuracy before go live. That's why we're working with veterans, providers, and Cerner and our VHA functional champion to integrate site readiness activities by embracing change management as the high reliability organization that we are, so we can set up each new deployment for success. By making these changes and others that I've outlined in my written testimony, we will get this effort back on track. We'll build an EHR system that allows veterans to access their healthcare records in one place from the first day they put on their uniforms to the last day of their lives. Because as Secretary McDonough has stated, this is a must-do, not a can-do for vets and providers alike. Thank you. I look forward to your questions.
Thank you, Secretary Remy. We will now begin the period of questioning. As a reminder to my colleagues, that members should pause 2 to 3 seconds before speaking so that all your questions are captured. I will now recognize myself for 5 minutes for questions. Mr. Remy, during the last hearing on July 21st of this year, I discussed with Dr. Clancy my concerns about the number of patient safety incidents in Spokane. Since then, I have heard from staff and leadership at the facility that they are still having grave concerns about the number of issues that have not been resolved. Some of these issues, especially in pharmacy, seem to indicate major risks to veterans. Mr. Remy, it has now been over a year since Grant staff went live with EHRM, and there are still an alarming number of unresolved issues with the system. Has a formal mitigation plan been put together, and can you please comment on it?
Thank you for that question, Mr. Chairman. And as I mentioned in my opening remarks, patient safety is incredibly important to me personally and to all at VA. And indeed, this is something that I've looked at, that I've studied, and that I've gathered information on. I wanted to understand where we are on patient safety issues that have been identified. And what I've learned is that, yes, sir, we do have a plan. We have a mitigation process to deal with any patient safety issues that might arise. And we deploy that any and every time they do present themselves. We've learned that going in, we need to understand that in a system like this, it's highly likely that a patient safety issue or any issue might present. And so what we've done is we've set up a system where anytime that occurs, it goes into a process so that we can understand the root cause, so that we can develop strategies to resolve the problem immediately, and so that we can put in place a mitigation plan so that it doesn't occur again, and that we can use the lessons that we've learned from that circumstance and assure that it won't happen in any future location or with any other patient. You've mentioned issues that have presented around prescriptions. We've looked at that. We've seen those patient safety issues that have presented. And I think the information that we have has allowed us to dive deeply into those questions, to understand what happened, whether there were technological challenges that presented the problems, or whether there was a human issue that might have presented a problem, and to resolve it and move forward. One thing that I'd like to say is, in thinking about how we process our issues, we've developed a system where we have categories and we put them into 9 different domains. I've talked about that. I'm happy to walk through those domains, but I want to assure this committee that we're taking patient safety issues very seriously, and we resolve them as they come through, and we learn from them and mitigate them as we resolve them.
Deputy Secretary, one of the issues that when I had a live conversation with the staff from Spokane is they said there was little visibility on the improvements or the plan on patient safeties that would come back to them so they would see. So they would make a complaint or they would make an issue of patient safety. Then they would return and there would be no visibility to them, either as leadership or staff, on what the fix of that would be. If you can articulate how that process is being mitigated so that staff on the ground has visible understanding and is aware of what is being mitigated.
Sir, the safety domain leads, the VHA staff, the EHRM councils or chairs, they conduct daily reviews around patient safety issues with the patient safety manager and talk about any new reports and any further analysis that needs to be undertaken to determine whether this is a known safety issue, a prior issue, or a new issue, and how to resolve that. I hear your question and the suggestion that there may need to be more communication to those that have raised the issue. That's something that I can take back and look into. But what I do know is that there is constant communication around issues that have been raised and around the resolution of those issues.
In your opinion, do these issues indicate a failure of the Cerner system, or are they problems with VA's workflows?
Mr. Chairman, I don't know that they're either. I think that in any circumstance where you're in a medical environment, you're going to have issues raised. What's important in a high reliability organization is that you immediately address those concerns, that you recognize what they are, that you take measures to avoid any patient harm resulting to the issues arising, that you learn lessons from what may have happened, and that you put in place protections for future challenges.
With that, my time has expired. I now recognize Mr. Rosendale. You're recognized for 5 minutes for your questions.
Thank you, Mr. Chair. Deputy Secretary, I'm going to stay right on this safety issue because at the end of the day, that is the most important thing that we are dealing with. And we have got such a horrible problem going on at Mayan Grandstaff right now that I think it needs to be brought to everyone's attention. So let me start right off with the real question. Do you believe that Mayan Grandstaff is safe?
Sir, I do. I believe that the issues that have been presented are issues that we look at, that we evaluate, and that we put measures in place to protect all of our veterans that are at the facility.
That's fine. That's fine. You don't have to give it a long explanation. I just want to hear a pretty simple yes or no. Back in April, Dr. Fisher testified that there have been 247 patient safety reports since the EHR went live. Are you familiar with that figure?
Yes, sir, I am.
Okay. Now I understand there have been 829 safety tickets, patient safety tickets since that time. 576 of those directly related to EHR. The system clearly seems to be creating safety risk. What are you going to do? What have you put in place since your governance to make changes so that we're not going to continue to see a repeat of this unacceptable number of safety tickets?
Sir, I have the data that you've articulated, and it's something that I've looked at personally. And what we put in place is a multidisciplinary team of experts led by patient safety professionals that can evaluate each one of these occurrences. I know that many of the times that we see these tickets, I think they're called tickets, be placed in, some of them are not patient safety issues, but I don't think that matters because many of them are. At the end of the day, what's important is that when these issues arise, you have professionals that understand how to address patient safety issues, taking care of the issue and understanding the issue and developing practices to move forward. So what I've done since I've come on board, and I've talked to Dr. Fisher about this as well, is tried to make sure that we have those systems in place, and I believe we do, that will allow us to appropriately evaluate any concern that's raised, to have the professionals that understand those concerns in place to look at this and to figure out the root cause, because you can't fix it if you don't know the root cause, and to develop plans for how to move forward and make sure that the patient that might have been involved in this circumstance is well cared for.
So here's my problem, okay? And this is what I've had from the very beginning of these conversations 10 months ago with Secretary McDonough. And that is that if we continue to see these problems arising at Spokane, and 576 of these tickets were related directly to EHR, okay? We don't have a fully functional system, and yet we are having conversations, and the Veterans Affairs is already redirecting resources to start introducing this system at other facilities. I've got a major problem with that. We've got 576 of these tickets directly related to EHR. And yet, a year into this, we're still having this kind of a problem. We're going to introduce this system at another facility. Please justify that to me.
Well, thank you for the question, sir. And I think, as I've articulated earlier, with these issues that have arisen, we've developed solutions. We've learned lessons from any issue that might arise and how to move forward so that we don't repeat that. The other thing is that—
So are you going to tell me, excuse me, Secretary, are you going to tell me then in Q4 here that I shouldn't be expecting to see any of these patient safety ticket problems, so that when you introduce this system in Columbus in February, everything should be working just fine? Is that what you're trying to tell me?
Sir, I think things will continue to improve. I cannot tell you that we will never have another ticket around a patient safety issue. I think that
Do you
those
think
things—
we're going to reduce it by 50%? Do you think we're going to reduce it by 70%?
I can't put a target number on it, sir, but I can say that as the
No,
system—
you can't. And see, and this is the conversation that we're having. We don't have a fully functional system in Spokane. And yet we're spending millions and millions and millions of dollars, and we're going to reintroduce this system at another facility. And that was not the agreement. Mr. Chair, I see that I've used my time. I'll yield back.
At this time, I recognize Chairman Takano for 5 minutes.
Thank you, Chairman Mervan. Mr. Secretary, the strategic review noted that, quote, empowerment of a government structure is needed, end quote, and cited stakeholder input as a key need. My first question, what does that structure look like to you, and when will you be able to share that structure with the Congress?
Thank you, Mr. Chairman. And the answer in reverse order is in very short order. We have been building in response to the strategic review recommendations, a new governance structure, a new organizational realignment to achieve the objectives of this program. What it looks like is, at the top level, making sure that all stakeholders for all issues around the deployment of this system are involved in the process at the ground level and at the decision-making level. And so inside of the organization at VACO, we have made sure that we've shifted responsibilities to the functional champion where they're appropriately should be placed, and shifted responsibilities to the Office of Information and Technology. We have that all flowing up into an executive in charge, a 24/7 dedicated individual that's an executive that will assure integration amongst all of those organizational units, and the decision-making process touching on our VA operations board, our VA executive board, to make sure that all components of the organization touch the decision-making process. And then below that, we have our councils and each of our various units working together from a governance day-to-day structure to make sure that we continue to have that input. We've included practitioners on the ground at all locations to have their input as we continue to build the system and prepare for deployment into future visions and future sites.
Okay, quickly, Mr. Secretary, when will you be able to share that plan with us? That structure?
We're working through this now. I hope to be able to have something to you in very short order. It's something that was one of the strategic review recommendations that I've looked at very carefully and built and planned. We're working to get all of our pieces together and our consensus, and I hope to have it to you really shortly.
All right. Well, that's a pretty, it's a very kind of vague answer. So I don't have a sense of your timeline.
Within the month, sir. I certainly will have it to you within the month.
Okay, thank you. That's what I was looking for. Mr. Remy, as Deputy Secretary, you are the accountable officer, accountable official over EHRM. Mr. Secretary McDonough has indicated his desire to install an executive between you and the program office to provide day-to-day accountability and visibility. What is the status of creating and filling this position?
Sir, we've created the position. We've got a job description. We're out in the market looking for qualified applicants to fill the role.
And what do you see as this person's role?
I think first and foremost, the individual needs to assure that we continue to have interoperability and integration amongst all of our components at VA. The person needs to, as the day-to-day executive in charge of the deployment, they need to have direct contact with our facilities, with our sites that we're going to deploy at, and they need to make sure that they're reporting through the governance structure any potential changes or modifications that we need to make. This is the individual that I would characterize as having the day-to-day 100% eye on the evolution of this program to help us all assure its success.
Well, sir, I imagine you're looking for a person who has experience implementing an enterprise EHR as an executive. Do you think that skill set is likely to be found within the government, or do you think you're going to have to go outside government to find that person?
I think that skill set is in the government. And I think the other component of it, sir, is that they need to be skilled as a change management executive, somebody who understands how to effectuate change, understands the technological delivery that's necessary, and understands the VA system.
So are you doing a search within the government, or are you looking also at possibly attracting people outside the government?
Both, sir, both. I'm sorry, I wasn't responsive. We were looking at both, but I do think that skill set does exist within the government.
Okay. Well, those are my questions, Mr. Chairman. I'll yield back.
Thank you, Chairman Takano. At this time, I recognize Representative Banks for 5 minutes.
Thank you, Mr. Chairman. Deputy Secretary Remy, is it accurate that you intend for your next Cerner go live in Columbus, Ohio to happen on February 12, 2022?
That's a really precise date there, Representative Banks. Our focus is in the first or second quarter of 2022 is when we intend to be able to deploy. And if I may, I want to make sure that everyone understands the distinction between deployment and go live. Because when we deploy the system, we're still in the early processes of making sure that we have training and testing, authentication, and user engagement and adoption before we actually flip the switch and have the system go live at a location. But it is our intent to deploy in February.
Appreciate that. So on that point, so far have the VA and Cerner completed all of their go live milestones in Columbus, including training, testing, interfaces, and everything else to be on track to achieve a target date in that time frame?
You know, again, sir, we've got the training, we've got the testing all set up. We've already started to socialize and received exceedingly favorable feedback. But this 2Q22 deployment is the deployment that leads up to the go live at a later point in time. So we'll be doing this testing, we'll be doing the training, we'll have sandbox exercises to make sure that the facility is ready to receive and that we've provided them with the tools to be successful.
Thank you for that. As Chairman Takano asked, I understand the organization that Mr. John Wyndham heads is being renamed from the Executive Program Management Office to the Program Management Office. What does removing the word executive signify to us?
Yeah, the structure that we're thinking about deploying that I promised that we would have to you before the end of the month recognizes an Office of a Functional Champion, a Program Executive Office, and the Office of Information Technology as the three key stakeholders, not the only stakeholders, but the three key stakeholders within headquarters to help drive this system home. I'm not entirely familiar with what you've just described, but that's how I envision structuring these three units.
So changing the name from Executive Program Management Office to Program Management Office, you can't elaborate on why you would take the name executive away from Mr. Wyndham's office?
Yeah, I can't, because I don't think that that's the structure that I'm presently envisioning. Right now it's called the Office of Electronic Health Records Modernization, OEHRM. And that's the unit that serves as the PEO, the Program Executive Office. And that's what it will continue to do, is serve as the PEO, the Program Executive Office. We will move some responsibilities over to the Office of Functional Champion within VHA and over to the Office of Information Technology. I'm not sure.
Deputy Secretary, maybe you could look into that a little bit more, maybe get back with us for the record.
I certainly will.
Deputy Secretary, is it accurate that VA intends to designate a new Deputy Chief Information Officer responsible for EHRM?
Within the Office of Information Technology, we want to make sure that there's a dedicated resource focused on EHRM. So yes, sir, we plan on, I'm not in a position to say what the specific title is, but we plan on making sure that there is someone that's focused on the electronic health records modernization program within our Office of Information Technology.
Can you tell us who that will be and what will he or she be tasked with doing that is not already happening?
So we haven't identified the individual yet and put them into that role. That's a process that's underway. But as I mentioned before, they will be the linchpin between the Office of Information Technology, the Program Executive Office, and the Office of Functional Champion within VHA, reporting up into this executive in charge.
Okay, I got a couple seconds left. The VHA Functional Champion, Dr. Cameron Matthews, is a very important part of the EHRM team. You would agree with that, right?
I think she's great. Yes, sir.
If this position was to become vacant, who would step into it? What qualifications and experience would that person need to have?
I think that person would need to understand what it means to be a functional champion for our clinicians, for our practitioners, be able to focus our efforts around making sure that this system is ready for user adoption. That individual needs to be focused both within VHA and within the overall enterprise that's focused on delivering electronic health records. And that's something that we're keenly aware of, the need for, and that's why we've increased the responsibilities of the Office of Functional Champion, recognizing, and indeed, this is something that came out of the strategic review, recognizing that role in that office is important to the overall success of the program.
Thank you. My time has expired.
Thank you. I now recognize Representative Schreier for 5 minutes.
Thank you, Mr. Chairman. Thanks for allowing me to participate in today's hearing. And thank you, Deputy Secretary Remy, for being here today and answering some of these tough questions. I'm here because veterans in my district, the 8th District in Washington, have been experiencing really unacceptable delays in care and specialist referrals, inability to schedule appointments online, and then when they try on the phone, impossible wait times on the phone. And all of this is not just delaying their care, it is compromising their care. This seems to be associated with the adoption of the Cerner EMR about a year ago, piloted at Man Grandstaff. And the community-based outpatient clinic of man grant staff that's in Wenatchee, in my district, serves veterans in 6 counties in rural north central Washington. And for many veterans, that's their only connection to the healthcare system. And for them, it's been incredibly frustrating, to be injured while serving the country and then unable to access the care that they were promised and that they deserve. And if you dedicated your life to protecting our country, it's really our responsibility to make sure you get the best service and the best care. And at least for the past year, and I'm hearing this from others, the VA is really failing our veterans. And Deputy Secretary Remy, I'm a physician also, and I worked at Virginia Mason Medical Center during their painful transition from paper records to Cerner. And I'm also a patient there. And so I now can schedule appointments online and contact my providers through the portal. I was wondering if you could walk me through how the VA has worked with veterans who tend to be older and less technologically savvy, perhaps, just to make sure that they know how to use this technology and feel comfortable with it.
Well, thank you for your comment and your question, Ms. Shire. And I could not agree with you more that it's VA's responsibility to assure that veterans are provided with timely access to the highest quality care. And to the extent that that's not happening, we need to make sure that we understand why it's not and take measures to assure that our veterans who have earned the right to have this care are being provided the care in a timely fashion, in a quality fashion. I also recognize that not all of our veterans are alike, and some are indeed, as you've described, older than others, and they approach our system in different ways. And what we want to make sure is that we meet the veterans where they are and we provide them with the services in the fashion that they're accustomed to. Some of the challenges, as I suspect you understand and recognize, over the course of the last 18 months, a couple of years, have been presented as a result of the pandemic. And the inability to connect in person is one of those things that has not been lost, but has been challenged because of the pandemic. We've been able to increase veterans' access to the healthcare system through telehealth and other measures to make sure that we're continuing to provide that care. But we recognize that some veterans approach the receipt of their benefits and healthcare in different ways, and we work to try to make sure that we meet them.
I'd love to point out too that I've had veterans, speaking of in-person care, they need a refill, can't get through on the line, so they try stopping by the clinic, they can't get help that way. They're just really coming up against all these walls. And I'm wondering if there's a tie-in between lack of access in person and on the phones with Cerner as well, because you referred to the survey that revealed that 80% of your employees said that as a result of the Cerner medical record implementation, my level of burnout has worsened. And I'm wondering whether you have had a mass exodus of employees, whether nobody can answer the phones because everybody's quit. Can you tell me a little bit about that and your staffing and what we need to do to make sure that just at least some warm body answers the phone for our veterans?
Well, thank you for that question. We actually, staffed up in advance of the go live in Spokane to try to make sure that we had resources to deal with some of the challenges that might present. I haven't been made aware of any mass exodus, but at the same time, I'm aware of this survey, and it is challenging to see reflected in the survey the number of individuals that are not having job and, for that matter, life satisfaction, and they believe that the electronic health record system is impeding their ability to do their jobs. And so we're looking into that. We're trying to make sure that we provide them with the information that they need so that they can understand how the system can actually make their jobs easier, how it can be more effective.
Of course, the fallout is on our veterans, right? Because if you have disgruntled staff, they're not happy on the phones, Cerner's not working, they get frustrated, and ultimately the ones who suffer are veterans who really need excellent care. So thank you for working on this. I appreciate it. I yield back.
Thank you.
Thank you, Representative Schreier. At this time, I recognize Ranking Member Bost for 5 minutes.
Thank you, Mr. Chairman. Deputy Secretary, the staff at Spokane has spent more than 44,000 hours training on Cerner EHR. Yet the medical center is still a mess after a year after the system has gone live. You testified 2 weeks ago, and then you testified again today that it must be a good product because of all the other hospitals that use it. So my question has to be, do you really believe the problem is with staff acceptance, or do you acknowledge that there has got to be some really fundamental problems with the EHR in Spokane as well?
Sir, I think there are three components to successful deployment of this system. That's the technology, the processes, and the people. And I think all of those have to work together in order to make sure that you can have a deployment that's successful at any location. And to the extent that there need to be technological fixes, amendments along the way, that's something that we look at. The processes, we've talked a little bit about that here today. We're making sure that we have a governance system and structure that can help make reasonable, rational, appropriate decisions to move forward. And the people. I don't misunderstand anything I've said to suggest that I'm blaming this on the good folks at Mann Grandstaff. I think that we need to provide them with the training, with the testing, with the tools, with the information so that they can be prepared to integrate a new system into their environment. That's true for our colleagues out in Spokane, and that will be true for our colleagues in any other location that we deploy the system.
Well, one thing I need to make sure of is that, that you recognize, and I want to know that you recognize the gravity of the survey that was taken, because I'm going to tell you, when you look around at the other people that are on this screen talking right now, if any of us had polls like what that survey was, we'd quit these jobs. I'll guarantee it, because those numbers are bad. And those are the people that are out there dealing on the front line. And I got to know that the VA and you and your leadership position are taking a position to, one, bring the morale up so that the service gets better and so that this product works.
I am committed to that, sir. When I saw the survey results, I reached out to Dr. Fisher. We talked about that. I'm actually going out to Spokane in a couple of weeks, but I'm just one person. Right. But I recognize that I am a person that has responsibility and accountability here. I want to make sure I understand what's going on the ground so that we can build systems to avoid the continuation of the morale problems that we see there in Spokane.
Well, let me tell you that, from what we saw there, that the Spokane staff, they have spoken in there, and the medical center is still not recovering in some areas to where it was a year ago. But you still intend to proceed with EHR in Columbus in February. How do you justify moving on to a different location when we really haven't resolved the problems where we're at right now?
Yeah, sir. A couple of things. One, we have engaged with the locations that we are contemplating deploying to, including Columbus and other locations in Vision 10, Vision 20. Even locations in Vision 12 and 23. And what we're seeing is a high level of excitement around the prospect of having this new technology available to the clinicians and the practitioners. Now, we got to make sure we get it right. And that's the point that I know you and the other members of the committee are making. And our experience at Mann Grandstaff doesn't illustrate that we were able to do that in the first instance at that location. And it reflects a continuing concern at Mann Grandstaff. We're working on making sure that the concerns that are expressed at Mann Grandstaff, the issues, we continue to address them, we learn from them, and that way, as we deploy to other locations, we can take those lessons learned and I believe be more successful.
So I'm short on time, and this next question is vitally important, and I believe it is. I know it is. The appropriations of $8.5 billion so far for this program. I appreciate that you declined to spend $720 million and carried it over to the fiscal year. However, it's a real possibility the VA will burn through this money before getting anywhere near completion. How are you going to reduce the spending and prevent the problem of overspending?
Well, as we did last year, and thank you for recognizing that, Mr. Chairman, we plan on being completely candid with the Congress and being transparent on these issues. And as we recognize that we weren't in a position to put that money on contract, even though it was multi-year money, we pushed it over into the next fiscal year. Our intent, our promise is to be transparent and candid and engage with this committee and other members of Congress on how we're spending the money to make sure that the taxpayers' dollars that are appropriated for this program are spent in a way that's consistent with that candor and engagement.
I appreciate that answer. And Mr. Chairman, I yield back. Thank you for the time. Over.
Thank you, Mr. Bost. At this time, I recognize Representative McMorris Rogers for 5 minutes.
Thank you, Mr. Chairman. Deputy Secretary Remy, I'm proud to represent so many in Spokane and the larger region who have served our country in the military. I want you to know that so far I've received 138 calls, emails, letters from veterans about their struggles with the Cerner electronic health record at Man Grandstaff. And I'm only counting the instances when they've identified the system as the cause of their difficulties. I have no doubt that many of these other complaints that my office have received are also related to the implementation. As others have mentioned, in the survey, a staggering 62% of the employees said that the electronic health record has made them question if they want to continue working there at Man Grandstaff. So my first question is just what immediate actions are you going to take to give the medical center the support that they need to make sure that we that we're providing safe and effective care to our veterans today?
Well, thank you for being here, and thank you for that question. And as I mentioned a couple of times, I really respect the concerns that your constituents have raised. We're trying to make sure we understand where those issues are arising, why there's that feeling of morale depletion, and what we can do to fix it. So what we can do to fix it, we recognize that in the absence of confidence and trust in the system, it will be a bit of a challenge to move forward. And so we're wanting to make sure that we bring all of the individuals that are impacted by this program, whether they be the practitioners or the clinicians or the veterans themselves, together to gather those data points and respond to them. In some instances, it may be that there is a very real concern that hasn't been addressed yet. We need to address that. In some instances, it may be a product of a lack of communication and information. We need to provide those data points in that communication, but our VHA partners, our Cerner partners, our program executive office, and our Office of Information Technology are looking at this survey. They're looking at the data, and they're
Mr.
looking
Remy?
at solutions. Yes, ma'am.
Mr. Remy,
Yes,
there's
ma'am.
a sense that you're moving on. There's a sense that you're moving on to Columbus and that you're done at Man Grandstaff. So I just, on behalf of the veterans in Eastern Washington, need to know that you are listening to their concerns and that you are committed to addressing these underlying technical problems that we continue to face today with the electronic health record in Spokane and in the larger region. So I'd like to hear just what are you going to do, even after this hearing, to reassure them that this continues to be a priority at Man Grandstaff.
Ma'am, you have my commitment that this is a priority. Man Grandstaff is a priority. All of our locations that we'll be deploying to will continue to receive treatment even after go live. I'm going out to Man Grandstaff in a couple of weeks. I've talked to the medical director there about the challenges that continue to persist and exist. And I'm going to personally get to some of the root cause here and make sure I understand it. But I know that our teams are already in place to try to help understand, or I should say, help those who are there understand that we're here for them, with them, while they're using this system, even if we deploy and when we deploy at other locations.
Well, I'm pleased to hear that you are making the trip to Man Grandstaff. I would love to work with you so that we could visit together and hear from the veterans as well as the staff that have been working so hard. This has been an extremely difficult time. We know that we're in a pandemic that has created a lot of strain on anyone that's in the healthcare field, and that's seen at the Man Grandstaff facility. And in addition to that, they have been putting in extra time to roll out a new electronic health record. We know that they are sustaining productivity losses. Over the last year, employees at Man Grandstaff have put in over 61,000 hours of overtime. 61,000 hours is nearly 7 years of overtime. in the middle of a pandemic. The staff are tired, they're frustrated. And to date, the electronic health record is making their job harder, not easier. So my final question is just, what are you going to do to restore the productivity levels to normal? And how do we accomplish that goal?
Ma'am, the burnout is something that we're feeling across the country, and it's particularly acute, I'm sure, at Man Grandstaff, because at the same time they're integrating a new electronic health record. And I recognize those challenges and understand the issues that have been presented. You know, I know in talking to the leadership on the ground that they're holding town hall meetings that the leadership is holding to make sure that they understand those concerns. And we talked patient safety earlier, that they're focused on those patient safety issues, user impact series for staff to come in and think about how to evolve as super users so that once they get that expertise, they can help deploy it to their colleagues. They can help their buddies understand how this system can work in this environment, and then perhaps even help those in other locations to understand that. At the same time, I know the leadership is focused on the issue of burnout, the issue of overtime, and trying to provide relief to those who are working in this environment so that they can take a break, which is incredibly important for everybody to do, particularly those that have been working so hard. So we talk patient safety, trying to make sure that we're validating all of the patient safety reports, that we understand what they are, that there's not this continued drumbeat where people believe that patient safety continues to be a problem, but rather people understand that when patient safety issues arise, we take them seriously, we address them, we provide mitigation measures, and we move forward. So again, I'm committed to making sure that our team at Man Grandstaff has what they need to continue to move this program forward and hopefully make it more successful across the entire country.
Okay, I'll put in a plug for that 27-hour, 24/7 urgent care facility. That would go a long way. Thank you, Mr.
ma'am.
Secretary. I'll come back for more questions later. Thank you.
Thank you, Representative. At this time, I recognize myself for 5 minutes. Deputy Secretary Remy, do you feel you have the sufficient authority in your position to make the changes and improvements needed to make this program successful?
Yes, I do, Mr. Chairman. The Secretary is certainly confident that we have the team in place, and we're building onto that team to deliver on the commitments of this program.
Then next, I know you've been in this position a short time. Have you or your staff identified legislative issues where you need support to be successful?
Thank you for that question, sir. That's something that we'll continue to look at. Right now, I believe the challenges that we've had that we've been talking about here today, it can be remedied by us through our activities in realignment and redeployment. But to the extent that we need legislative initiatives being put forward by the Congress, rest assured we'll come to talk with you about that and work with you on that.
And then through today's testimony, we've talked about a lot of patient safety issues. Something that rang out to me, and specifically in the pharmacy, was the ability to be able to put in orders that are wrong. In the last system, it was the operation would stop it. And what I had heard in testimony is that the pharmacy and their staff are going above and beyond to try and protect veterans from this. Can you elaborate on what some of the work orders may be, or change orders that would be able to provide the pharmacy staff the support that they need now in Spokane to be able to remedy that situation?
Yes, sir. I have heard of some of the challenges with prescriptions and the manual workarounds, if you will, to deal with those challenges. You know, what the clinicians, the pharmacists and the team on the ground are telling me is they need to make sure that this new system doesn't put us in a position that appears to be worse than the prior system, and that we don't have so many inefficiencies that we can't deliver our pharmacy needs to our veterans in a timely and effective fashion. What I'm doing is looking at how these two systems operate and making sure that we have the tools, the testing, the training in place to get our pharmacy team to be able to use the system in an effective and efficient fashion. Some of the issues that have arisen on the pharmacy side were difficult issues where it was hard to break down the point of failure along the way. And so that's something that I've also asked the team to look at so that we can make sure, as I've mentioned before, whatever lessons need to be learned from that process, we can. But for the pharmacy team in particular, I want them to know that we do understand those concerns. We do understand the inefficiencies, and we're working with Cerner to make sure that this system, as it evolves, can meet the needs of our practitioners and clinicians.
Okay. And then quickly, I've heard that there have been a survey of personnel at Man Grant staff related to their morale and job satisfaction. The data overwhelmingly indicates that staff is unhappy with progress of Cerner and the rollout, that it's making their job harder. Have you or has the VA considered conducting an independent review of the EHRM program, perhaps bringing in outside experts of the EHR deployment?
Sir, as you know, we've had a GAO review, a couple of OIG reviews, a strategic review, and we're in the process of implementing the recommendations from all of those reviews to help enhance the way we deploy the system. At this point, I think it's been mentioned before, one of the things that this committee wants to see, indeed that I want to see, is the progress of and success in implementing those recommendations. I think when we have that data, it will help us understand that we do have a path forward to success that doesn't necessitate yet another review of the system at this point in time.
Also, one of the points that they had made when I had an opportunity to speak with the staff was that the specialty, they felt testing getting back to them, that the infrastructure, the network itself was on a delayed process. And not nitpicking, but it doubled the time in order to get results back in communications. Are you aware of that? And if so, what type of solutions do you feel are in order when they're speaking to the infrastructure of the old networks?
I'm not sure that I'm complete. Are we talking about the Oracle upgrade, sir?
Specifically, they were the specialty side of the cardiology, for example, or other testing physicians that were on the specialty side of things said that the time to get results back were almost double in time, where when it would be 10 minutes, it's now 20 minutes. And they felt that it was based on connectivity and also the ability for the networks to work at a quicker pace, but that it wasn't as fast as it was in the past to break things down in a simplistic way.
Well, sir, I'm happy to take that one and get smart on it. I don't know about it in any specifics, but I will say, that our investment in the infrastructure, the technology infrastructure across the board is something that we continue to be focused on to make sure that we keep in the forefront to assure that we don't have technological failures that are avoidable because we failed to invest in the infrastructure necessary.
Okay. I just want to make you aware that not only linking on to Cerner was an issue that they brought up, but also, as I mentioned, the time in which they were able to get those results back. At this time, I've gone over my time. I'd like to recognize Ranking Member, Congressmember, Ranking Member Rosendale for 5 minutes.
Thank you, Mr. Chair. Appreciate it. Deputy Secretary, I agree 100% with my good friend from Washington, Representative McMorris Rogers, that it seems the Veterans Administration is trying to basically close off or ignore the problems at Man Grant staff and try to have a do-over. And that is very problematic. It's like we're trying to ignore all of these problems and we're going to do it better next time. We promise you. And so just continue to give us this money so that we can proceed down the line and do it better next time. I'm not buying into that. We've got a lot of people over there that have suffered safety problems. We've got a lot of employees that are having major problems. And on that line, do you believe that the deteriorating morale is a significant risk to staffing and ultimately to the veterans' access to care at Man-Grandstaff?
Well, Mr. Rosendale, I am deeply concerned about the morale issues that are reflected in the survey. We've talked about that earlier, and I'm hopeful that the measures we're putting in place and understanding the genesis of those concerns will help enhance morale at Man-Grandstaff. I want the folks there to know we're not forgetting about them, and we're not trying to brush them to the side. And we're hopeful that we'll be able to make sure that we're delivering them the tools today and tomorrow to continue the success of the program.
Well, let me ask you, the employee survey is startling. As Representative Boss said, if anybody sitting in this committee right now was trying to get reelected with those kinds of numbers, I assure you, we would not return to Congress. They're pathetic. They are terrible numbers. 83% of the employees, 83% of the employees say their morale has worsened as a result of EHR. 75% say their job satisfaction has worsened. 62% has made them question whether they want to continue working there. I mean, these are really, really bad numbers. Do you find that an emergency situation?
Well, sir, I am equally concerned about that survey and the results of the survey. It is something
I understand your concern about it, but do you consider that they are severe? I mean, this was just conducted in August, September of this year, after this had been implemented for almost a year. So we're not talking about 30 days in when it was first introduced, okay? We're talking about after a year of extra support, all the extra workarounds, everybody trying to do their best to implement it. Do you find now at this point, that this has risen to an emergency situation?
Well, it's certainly risen to a situation where we have to engage and double our engagement with the team on the ground to make sure that we're providing them the support.
You don't feel it's an
they need.
emergency? Don't you feel that?
I'm sorry, I didn't mean to interrupt, sir.
You don't believe that it's an emergency when you have 80% of the people there that feel that their morale is that low?
I think it's something we absolutely have to tend to immediately, and we
Okay,
are.
so if we need to attend to it immediately, okay,
Mhm.
Why is it that you're not scheduling a visit out there for several weeks?
I'm going out there next week after next. This was the first available time with schedules.
Deputy Secretary, if I had those kinds of problems taking place in my business, I would be there tomorrow morning. We're talking about major problems, okay? And there's flights to Spokane daily. I am sure McMorris Rogers representative, the good representative, would help get something scheduled there. You need to be there tomorrow. This is a major problem.
And sir, I think, as I said earlier, when we got the results of the survey, the first thing I did was reach out to the folks at Man-Grandstaff to start planning a broader engagement with those folks on the ground. So I understand the gravity of the moment. I understand the concerns of those individuals at Man-Grandstaff, and I want to make sure that I understand exactly where they're coming from, and that's why I'm going out to Spokane. Remember, this survey is the product of one of the recommendations that came out of the strategic review. One of the things we wanted to do was to make sure that we continue to keep our finger on the pulse of what's going on, and now we have the data point, and we've got to dive more deeply.
Mr. Chair, I'm right on the button. I will yield back.
Thank you, Mr. Rosendale. At this time, we recognize Chairman Takano for 5 minutes of questioning.
Well, thank you, Chairman Mervan. Mr. Undersecretary, I want to expand upon the survey at Man-Grandstaff, which indicates that staff morale and job satisfaction are remarkably low due to the EHRM implementation. Have you drawn your own conclusions as to why staff morale and job satisfaction are low, having looked at the survey results?
Sir, I think there are multiple reasons, but this is one of the factors that has prompted me to desire to go and be there myself and hear from people directly. We've talked a lot about here and recognize the reality that we deployed a new electronic health record system during the pandemic. And so there were great challenges to the work environment already for our team at Man Grant Staff. And I think that has exacerbated the impact on morale, recognizing how hard people are working to serve our veteran community, and at the same time trying to understand how the system is going to work within their environment. I recognize that there also are some of the challenges with the training that we had early on, and we've developed modules to improve the training and information that's provided to those individuals that are going to be deploying the systems, the practitioners in the community, and made that better. We talked a little bit here about communication and information. We want to make sure that our practitioners understand if there's an issue raised, how that issue is resolved. And I believe that our leadership team on the ground in Man Grant Staff is engaging in that type of communication to help our teams understand what the environment is. So, I still need to gather more information to totally understand the genesis behind the survey results, but I'm working toward that.
Well, Mr. Undersecretary, I am happy to hear that you are traveling to Spokane, and obviously one way that you're trying to address the staff's concerns is to actually go there and listen to them yourselves. So that's one feedback mechanism, as they can directly report to you. But one really good practice in information security is to provide an opportunity for the end users, the rank and file team members, to report risks or vulnerabilities, including a way for them to report anonymously. Does such a mechanism exist for that kind of feedback from the staff?
Candidly, Mr. Takano, I should know the answer to that question. And I don't. I know that the users have been able to provide feedback. I need to familiarize myself with whether there's the capability to do that anonymously, and I'll get back to you on that immediately.
Yeah. If you could get us, some information about the feedback, about the feedback mechanisms. We're hearing that from one physician very recently, that, quote, there appears to be a Microsoft InfoPath form for reporting patient safety concerns. And he says when he tried to use that mechanism, he was pinged for a login with his PIV, and he couldn't use it. So I'm just concerned that the mechanisms you have for staff people to give you feedback may not be facilitating the kind of frank information that you need from people, and giving people the sort of the safe avenues and the safe mechanisms to be able to tell you the things you need to know. So if you could get back to the committee and let us know what you're discovering, and if indeed people, staff members do have this ability, I'd appreciate it.
No problem, Mr. Takano. I believe with all of the reports that we've received from Man Grant staff, I'm hopeful that that's evidence of a culture that actually embraces people reflecting what their concerns are and raising them.
All right. Thank you. I yield back. Thank you for being here. And as many as others have said, you weren't here when all of this got started, and when the initial phase was implemented at Man Grant staff. You are on the hot seat now, and you've responded with remarkable aplomb and coolness. And I appreciate what it takes to be here today. So thank you.
Thank you, sir.
I yield back.
Thank you, Chairman. With that, I recognize Representative McMorris Rogers for 5 minutes.
Thank you, Mr. Chairman. I really appreciate you allowing me to be a part of this hearing today, and to the Deputy Secretary. Appreciate you answering all these questions, and it's good to know that you're coming to Spokane. I hope to coordinate schedules with you so I can join with you. I wanted to just ask a few more questions. One of the big issues has been as others have mentioned, has been the employees feeling like they have to do these workarounds. And I just wanted to ask what is being done so that the employees don't feel like they have to do these workarounds, and how are we addressing the underlying technical problems?
Thank you, Ms. McMorris Rogers, and I look forward to seeing you as well. One of the things that I've learned in the couple of months that I've been in this role, and talking to my colleagues at DoD and my colleagues in the private industry that have deployed not just the Cerner system, but other systems as well, is in the early stages of deployment, these are the types of things that you deal with, and that you learn from, and that you grow from, and that you evolve. You would hope that you could take all of the lessons learned from everyone else before you go live at any location and put them into your system. And that way you can have a flawless execution on day one. I haven't heard anybody tell me yet that actually occurs. And so what we're doing is trying, as we learn about workarounds, as we learn about interoperability challenges or other problems that might inhibit the ability of this system to be efficient, we're developing solutions around those things. And that's why it's so important, to Mr. Takano's point, for people to raise these issues, to raise these concerns.
Thank you. Thank you. You said that we evolve. My concern is that we're not evolving, that I continue to hear the same, kind of the same drumbeat, and certainly around pharmacy, that's one of the biggest drumbeats that I'm hearing. It perhaps is the number one concern. And I guess the question is, because others have asked about pharmacy, even if the Cerner system was designed this way on purpose, do you agree that the system's complexity is creating difficulties, and what's being done to reduce the complexity so we don't get these duplication or wrong prescriptions being filed?
I think that there are a couple of things at play here, ma'am. I think that, as I mentioned earlier, one of the challenges that we had before we launched and went into a go live mode was to make sure that we had adequate training and information in the hands of the clinicians so that they could understand what the differences might be and be able to execute on those differences. And so now we've developed systems to provide better and greater level of information to try to avoid some of this in the future. With respect to the prescription issue in particular, my understanding is that we are engaged in assuring that the technology that Cerner has provided to us can work in our environment so that there aren't continuing prescription issues. I think some of the issues, I'm sorry, go ahead, ma'am.
Well, thank you. I guess I'd like to ask specifically about the patient portal, because we continue to hear of too many errors, too many delayed medications, and it involves the patient portal, but there seems to be a debate about whether the portal itself or the other systems interfacing with the VA are causing the problem.
Yeah, so an example was shared with me about the use of the patient portal, where there was a patient who used the portal for the prescription, but they didn't receive the prescription.
Exactly.
And so they contacted the pharmacist and said, okay, I put this prescription in and I haven't received it. And the pharmacist realized that the prescription wasn't reordered. And so as the team looked at that challenge, they were trying to figure out where the breakdown occurred. And what I understand from that circumstance is the breakdown occurred because there was an expectation that there would be follow-up around the failure of the prescription to arrive. And when that follow-up didn't occur, we should have had a mechanism that flipped the switch and said, hey, follow-up hasn't occurred. Let's make sure this prescription is filled. It wasn't. And so that's the type of example that kind of is in this gray area that I know people are working on.
Well, it's just much too complex. And what I hear is that doctors and nurses are spending valuable time every day at the beginning of a veteran's appointment to reconcile the medication with what's in the system, and is causing a lot of challenges. And the problem was something in the initial data migration. And my understanding is that the VA solution has been to reduce the amount of medication that's being checked. That's not the right approach. So I'm thrilled that you're coming to Man Grand staff. I hope that I can join you, talk to veterans, talk to the staff, and really get to the root of some of these continued issues that we face every day at Man Grand staff, and address them before we are rolling out this same electronic health record to other facilities. And I just thank the committee for your vigilance and look forward to continuing to work with everyone on the committee. Thank you.
Thank you, Representative. At this time, I recognize myself for 5 minutes. Deputy Secretary, clearly the program still has a number of issues that need resolution. This is understandable considering the size and complexity of the program. 2 questions. Moving forward, how will the sites be selected? And 2, what milestones must be met to move forward to the next specific sites?
Thank you for that question, Mr. Chair. We talked previously about making sure that we have a current state of readiness for any site that we're going to deploy into the future, that we look at this from an enterprise-wide basis and examine where we may be able to go that's ready to receive the system. We evaluate Cerner's performance based upon the contractual metrics. We've talked, maybe not at this hearing, but I know before, about Cerner having contractual metrics in their system, looking at the veteran experience and the quality and safety, workforce support and healthcare operations as components of that. And we're also looking at trying to make sure that a deployment site and the success of that deployment site be evaluated on factors that we've developed and metrics that we think we can assess from an operational perspective. And as we do that, those are things like access times, appointment time, prescription data that we've been talking about, revenue collection, clinician productivity, care coordination, system or network performance, and veteran portal usage. That's how we'll be able to evaluate when we get to that site, whether or not, as we're in this deployment phase, we're having success with the system at that site.
And then I appreciate you taking the time last week to get on a call with me ahead of this hearing to address my concerns about the issues in Spokane. On that call, you committed to being transparent with the subcommittee and providing us the documents we need to perform proper oversight. We still have not received the full list of patient safety risks identified by the personnel at Man Grand staff. Can you confirm with us when we can expect to receive that information?
Sir, after our conversation, actually before our conversation, and then again after our conversation, I've checked with the team to who's developing that information, and we hope to be able to provide you with something shortly. What I do want to make sure that I convey is that it's a dynamic set of identified issues, because we continue to receive information and we continue to resolve issues along the way. I think that Ranking Member Rosendale pointed out that the number of issues that were identified a year ago has risen quite substantially to today. So what I simply want to make sure that I convey to you is, as we provide you with the data, know that we also want to make sure that we have a constant mode of communication, reporting to you, meeting with you or your staff to update that data, because it does change regularly.
Thank you. And then finally, I have a number of important cybersecurity and privacy questions that we did not have an opportunity to address. We'd be happy to submit them for the record if you can commit to providing us with prompt answers.
I do so commit, sir.
Okay, I thank you. At this time, I'd like to recognize, I yield back my time. At this time, I'd like to recognize Ranking Member Rosendale for 5 minutes.
Thank you, Mr. Chair. Secretary Remy, I want to ask you some questions about the program's key performance indicators, which Cerner reports as part of its contract. First of all, it appears that performance in Spokane is being measured today compared to the period just after the EHR went live. To me, and I really think to most of the people on this committee, that data is not as relevant as what was the data prior to Cerner introducing this system. Okay, so what I'm trying to find out is I want to know how the performance today compares with before the EHR went live. Can you provide that data for us?
Yes, sir. I will gather that data and provide it to you. I will share one thing with you right here in response to that comment on data that I have received, that I was asking a very similar question to the one that you posed around what the patient safety reports have been. And I understand from that data that prior to the deployment of the Cerner system, that patient safety reports related to the EHR, the Vista system that existed then, were a lot lower, substantially lower than the patient safety reports that you reflected on in the data that you talked about today. And so I'm going to dig into that data and that information and understand more of why it's that way. But I'll also talk to our colleagues at Cerner and our team on our PEO office about looking back before deployment.
Very good. Thank you. Let me read you some of the key performance indicators. In August, there were 164 employees reconciling veterans' medical records that were migrated into the Cerner incorrectly. A year ago, 181 employees were doing that. Why are so many employees still cleaning up medical records? And how bad was the data migration that's still being sorted out?
So the challenges with data migration, sir, was one of the things that was identified in the strategic review. And it's one of those issues that we're working through to try to make sure that the measures of success, to your point, reconciling the challenges around data migration in a way that creates efficiencies but doesn't exacerbate burdens, is something that we're keenly focused on now. So we've got a team that's looking at the data migration issue to make sure that we can do this in a way that's efficient.
So in August, 57% of the veterans were being seen within 15 minutes of arrival. A year ago, it was 50%. So that's a slight improvement. But anything that's in the 50s, quite frankly, is unacceptable. And again, trying to establish what kind of performance we had prior to EHR as opposed to when it began and how we're moving forward. I'm trying to figure out what was going on before so that we have a true comparison. What was the number before Cerner EHR was installed?
Yes, sir. I don't have that data, but as I mentioned earlier, I'm committed to identifying that for you. I think it's also important to, as we continue to deploy the product, the electronic health record at Spokane, and as we take the measures that I've talked about here today to help our people in the community deploy this and operationalize it, I think the data set from that will be useful as well.
And looking at the actual lab test, we had some questioning about that earlier. The turnaround time for lab tests is 51 minutes compared to 45 minutes a year ago. Do you have any kind of feedback on why that is?
I don't know the issue specifically, sir, but in general, you ask for any kind of feedback. In general, I understand, again, from talking to others who have deployed new electronic health records, that in the early days, challenges are presented, and in the early days that you may have these reverse data points that you've just described, reflecting some level of inefficiency. But as people get more familiarized with the system, and as you make sure that they understand how to work it, I understand that trend, if you want to call it a trend, reverses.
I would certainly. I mean, have they given you any estimate of time? A year's time is pretty long to be able to adjust.
I can't pinpoint how any particular system in any particular facility has worked, but as a general matter, what those who have deployed new electronic health records have shared with me is that you do have this cycle and it does get better.
Mr. Chair, I'm out of time. I would yield back. Thank you.
Thank you, Mr. Rosendale. At this time, I'd like to recognize Chairman Takano for 5 minutes.
Well, thank you, Mr. Chairman. Mr. Undersecretary, you've heard the dissatisfaction that the committee is hearing from staff and leadership in Spokane regarding the new EHR system, whether it is the training provided or the difficulty it creates in providing care to patients. The common theme is that there are issues, and the staff working with the new system don't feel that their concerns are being taken seriously. Now, I have to say, from my own perspective, from the recent history regarding issues with VA's ability to manage and run IT programs generally, I tend to think that VA bears some portion of the responsibility for these issues, that they're not coming from Cerner alone. So now that you have had a chance to review how the EHR program is structured, do you plan to address concerns regarding VA's ability to manage the Cerner contract?
Yes, sir. I think that we make sure that we have the line of communication that's necessary to understand when or if Cerner may have challenges, but as importantly, to clearly communicate what the expectations of the department are to our contractors so that they can execute on those expectations. I believe that we have a structure in place. We've talked about how we're modifying our structure to realign to be able to execute properly and efficiently and effectively. One area of realignment is also to make sure that our relationship with Cerner is one where we have the line of communication that I've described before. I think in the past that has been there, but we can shore it up. And I think making sure that we have all of the key stakeholders around the organization engaged in our Office of Management and our Office of Acquisition in this process is important for us to make sure Cerner understands what their obligations are.
Okay, well, what level of participation does Cerner have in your current attempt to address public safety, patient safety issues?
Cerner's at the table with us for all of the processes that I've described previously. When we gather the functional groups together to evaluate those issues that have been raised, Cerner is a participant in those processes.
Well, great. Well, thank you. In our July hearing with VA and the VA OIG, it was revealed that when issues from VHA were reported to the OEHRM, they met resistance from OEHRM leadership and were not included in decision-making discussions. This specifically was referring to the inadequate training that was resulting in concerns for patient safety. Now, what has been done since our last hearing to remedy this particular issue?
Well, a couple of things, sir. We have, as I mentioned earlier, enhanced the role and responsibilities of the Office of Functional Champion. We've made sure that the VHA team, not just those VHA individuals that were part of OEHRM, but our team of clinicians and practitioners on the ground are participating in the dialogue around how we build out the training and how we make sure that that training meets our user needs. Cerner is also involved in those conversations so that we can enhance our training. We're building a system where we can ultimately have super users that can help train moving forward. And lastly, what I'll note is that eventually we envision a world where VHA will own the continued operationalization and have a greater role in training across the board.
Well, that's interesting that you say that VHA will eventually own the implementation. There was also an instance where feedback provided to the OIG by OHRM had to be corrected and resubmitted by the acting deputy secretary, which the IG stated was not a common practice. So it's obvious that there are issues between VHA and OHRM. Can you tell me what steps you're taking as the not the acting, but the deputy, the undersecretary, to fix this relationship.
Sure, sir. And if I said VHA will eventually own the implementation, I thought I was focusing on training. And let me just clarify myself there, because what I was trying to convey is as we move forward, we want to make sure that those clinicians are integrated into the training process where they can train their colleagues. As it relates to what I mentioned in my opening remarks around silos, that's something that as we build out the new organizational structure with realignment, I think we can make sure that we don't have those challenges that the IG reflected in the IG report, that we have the role of the functional champion clearly defined, not just as it relates to the PEO, EHRM, the Office of Information Technology, but as it relates to our governance structure, so that there is this sharing of information. There is the understanding of various perspectives and positions. There is a dialogue around everyone is at the table, gets to articulate their perspectives, and we make a decision as an enterprise based on all of the best information. That's how we're structuring the electronic health records modernization program at VA for the future.
Well, thank you. Thank you, Deputy Secretary, again for appearing before this subcommittee. And I yield back, Mr. Chairman.
Thank you. At this time, I recognize Ranking Member Rosendale for 5 minutes of questions.
Thank you so much, Mr. Chair. Deputy Secretary, what kind of penalties or repercussions have been imposed on Cerner because of the total failure of this EHR rollout?
Well, sir, we're still working with Cerner on how to correct any challenges of the past, and we're looking forward to how we get to the future. I'm not aware of any penalties that have been imposed, but rather a continued collaboration with our contractor about the needs of the agency, the expectations of our veterans and clinicians, and how to make sure we get this right.
So who's going to, as I look at this chart, who is going to be the person who's going to be the direct point person who's going to be involved in conversations about the actual contract and being able to hold them accountable on this organization chart?
Well, to hold them accountable, ultimately, I think it's partly my responsibility as the executive who has accountability for this program. But the day-to-day engagement with Cerner will occur in our program executive office the way that it occurs typically with government contracts.
So you're going to be the person who's ultimately responsible for that conversation and those negotiations?
No, I did not mean to suggest that. We do have contracting professionals that exist within our program executive office that will engage with Cerner on a regular basis about the expectations of the agency and their obligations under the contract.
Okay, so when we look at the reports and we see the 80% dissatisfaction rates, and we see the safety, again, that really concerns all of us on this committee, the safety tickets that are being issued. When we see the total failure of this EHR system in Spokane, what penalties or repercussions? There's got to be something that you and your staff are going back in and saying there's a penalty because of that. Don't you agree? Or do you feel that we should continue to fully compensate an organization even though they did not deliver on their contract?
Well, sir, I think the contract spells out the expectations and the deliverables that are required of Cerner. And we'll certainly make sure that they're compliant with the contract. But the way that we're approaching these issues is working together with Cerner, and they've been cooperative in this regard in making sure that we develop solutions.
Offense, Deputy Secretary, but I'd be real cooperative too if I was receiving billions of dollars, okay? They should be up kissing your ring, quite frankly. They're receiving billions of dollars, okay? And who's not receiving the product or the staff and the veterans over there in Spokane. And I am telling you that I've been in business for my entire life, okay? And I have never, and would I ever, continue to compensate an organization with such a failure of a record of a product that they were supposed to be providing me. And I have got to ask you to be the hammer, because I can't be that hammer. Okay. But we need you to be the hammer to say, you're not providing the service that you contracted for. We've got a failure time after time again. And so you need to be able to use that as a tool to make sure that we can make these improvements going forward. Let me ask you something. You placed over $500 million on contract in the final days of September. $500 million. What exactly were those funds directed for and used for?
Sir, they were used for infrastructure. They were used for preparing for future sites. They were used for the offices, to the program offices, to make sure that we were continued to be operational. We were looking at making sure technology is current. One of the recommendations and suggestions that came out of the OIG's report. But as importantly, what I can share with you is what we didn't do, which was put another $700 million on contract that would have been placed for deployments that we weren't ready to go to at that point in time. And so
I mean, I appreciate that, but $500 million still went out the door to Cerner. What a terrible, day they must have had that evening when they received those funds. I'm sorry, they are not performing, and yet they are being rewarded. And that is not the proper way to run this organization. Mr. Chair, I see my time is out. I yield back.
Would any of my colleagues care to add any closing remarks? With that, I would like to thank Deputy Secretary Remy for his participation today. As Chairman Takano mentioned, sir, I realize this is a new position. I realize it has great magnitude through the VA and the entire enterprise. And being able to provide a world-class healthcare and benefits to the veterans is our top priority. That being said, my meeting with the staff and leadership in Spokane had a profound impact on me. And I plan to continue to be an advocate for the frontline staff at Spokane and future locations that deploy the new EHR system. Mr. Remy, I want to encourage you to reach out to this committee for any assistance you require to expedite resolving the issues being experienced by staff in Spokane and ensure that patient safety continues to be our #1 priority. The ranking member and I have been looking to schedule a trip to Man Grandstaff, and we certainly would love the opportunity to join you and to see firsthand the situation there and what the VA is doing to address those concerns. With that, in closing, again, we've gone through a lot of different subject matters, and ultimately we want to get this right. We want to get it right. We want to be efficient with taxpayer dollars, and we want to make sure that we eradicate any patient safety issues through this transition to Cerner. This is important work that we're doing. Success is the only option that we have, and we have to get this right as we move forward. I look forward to working with you in a partnership, but understanding the urgency and the advocacy that we must have for the frontline workers in our medical world that are producing healthcare for our veterans. That being said, I appreciate and am grateful for your efforts and joining us today. And in conclusion, want to go forward with you knowing that we are working together to find these solutions. At that, I want to let everyone know all members will have 5 legislative days to revise and extend their remarks and include extraneous materials. With that, this hearing is now adjourned. Thank you.